So first, before I read Anne's bio, I want to acknowledge that Sean A. Bear was going to also be one of the hosts of this session. Unfortunately, is not able to be here today, but he is the co-director of the National American Indian and Alaskan Native Technology Transfer Centers, and involved with the University of Iowa College of Public Health as well. And he is a member of the Meskwaki tribe in Tama, Iowa, and does work with Native Americans with substance use disorders. So we just want to acknowledge that he does a lot of this work as well. We are missing him today, but we wanted to definitely give props to Sean for all the good work he does. Okay, so now I will move on to Anne. So Anne Helene Skinstad, I hope I'm pronouncing that correctly, is a clinical professor in the Department of Community and Behavioral Health, College of Public Health at the University of Iowa. She became the program director of the first National and Alaska Native Addiction Technology Transfer Center, ATTC, in 2012, funded by the Substance Abuse and Mental Health Service Administration, SAMHSA. She became the program director of the National American Indian and Alaskan Native Mental Health, TTC, and the program director of the National American Indian and Alaskan Native Prevention, TTC, from 2018. She also became the program director of the National American Indian and Alaskan Native Child Trauma TSA from 2021. Prior to the most recent projects, she directed the Prairie Lands ATTC serving Iowa, Nebraska, North Dakota, South Dakota, Wisconsin, and Minnesota, which is also funded by the Substance Abuse and Mental Health Services Administration. As the director of TTCs, she oversees the center's workforce development initiatives, the development of training curriculums for substance use treatment in different special populations, including women, clients who identify as lesbian, gay, bisexual, and transgender individuals, clients with co-occurring substance abuse and mental health disorders, including gambling disorders, and American Indians and Alaska Natives, clients with behavioral health disorders. She has overseen the development of videos, especially addressing the needs of American Indians and Alaska Natives, Sucker Punch, Nagi Kakopi, and Finding Purpose, Recruiting American Indian and Alaska Native into the behavioral health workforce. Thank you, Dr. Skinstad, for joining us today. I will let you take it away.
And thank you very much, Maddie, for doing this. I really enjoy working with such an important group on campus. What we would be able to do without the library system, I do not know. So I want to thank you up front for how much you have meant to us, to the students through the years. One thing that Maddie did not mention is that I'm a Norwegian clinical psychologist. And a lot of people are asking me, what on earth did a Norwegian end up in Iowa and then working with natives? I think I will try to explain that as we go. One of the things that we always start with, and that is to acknowledge the land we are on. And as you know, we have a land acknowledgement part of the University of Iowa. And I want you to go to that and read what kind of an extensive history is associated with the state of Iowa and the tribal community in the state of Iowa. What we usually do is we would like to sort of acknowledge that since we are a national one, we address the whole country. And the importance is to pay respect to the indigenous nations whose homelands were forcibly taken over and inhabited. Past and present, we want to honor the land itself and the people who have stewarded it throughout the generation. This calls us to commit to forever learn how to be better stewards of these lands through action, advocacy, support, and education. We acknowledge the painful history of genocide and forced occupation of Native American territories, and we respect the many diverse indigenous people connected to this land on which we gather from time immemorial. While injustices are still being committed against indigenous people on Turtle Island, today we say thank you to those that stand with indigenous people and acknowledge that land reparations must be made to allow healing for our indigenous people and to Mother Earth herself. This is something that two of our students in our center created, and that's Ella Driscoll and Keely Driscoll. They are siblings, and the names before their Western name is their Indian given name. And here again at the end is Sean Bear, who was supervising this. We always have to acknowledge our funder. So again, Maddie said SAMHSA, and SAMHSA has been very generous to us from 1994. And the history, I'm not going to go through a lot of it, but the TTC, the Addiction Technology Transfer Centers, really are the flagship of the SAMHSA portfolio. And we have been funded since 95, and we were a regional center and served many of the upper Midwest states before we became the National American Indian and Alaska Native ATTC. One of the things I wanted to highlight is the beginning of why we ended up being focused on the tribes in the upper Midwest. And that was in response to a request for proposal. And my advisory council at that point sat around and I looked at them and I said, what states do you think I should add? Because that was my charge. I could do whatever. They said, let's align ourselves with the Aberdeen Area Indian Health Service. That's what it was called. And that consisted of Iowa, Nebraska, and North and South Dakota. And the rest really is history, because what we did was, at that time, I hired Native American coordinators in North and South Dakota. And the one, my elder, is the one you see here talking to me in a very much younger version than I'm now. And his name was Wayne Mackey, and he was a faculty member at the University of South Dakota, and he was a Santee Sioux tribal member. He made a huge contribution to what we do now and also what we have been doing before and after. And his motto was, look forward, but never forget what happened to the people in the past. And he passed away, unfortunately, so prematurely in 2010. And I established a memorial lectureship in his name, and his native name was Waktayanaji. And it means proud. I know, I forget what it means now. I should know. But he was also a retired sergeant from the armed forces. From an ATTC to the Native Center for Behavioral Health, we look like this at the moment. And I don't expect to have you remember all this, but there are the main three TTCs, the addiction TTC, the mental health one, and the PTTC. But then we also have the Tribal Opiate Response Grant, the TOR, and we have school mental health. And the latter have resulted in the current grant that we are really excited about, called the the National American Indian Alaska Native Child Trauma YMCA. We also have a leadership academy, and that was what originally your colleagues asked me to address, but I will address it in a bigger picture. Let's remember what the population looked like. In 2010, the definition of who could be called a tribal member and Native American was much more narrow than what the census did in 2020. And OMB defined in 2020 American Indian or Alaska Native as a person having origins in any of the original peoples of North and South America, including Central America, and who maintains tribal affiliation or community attachment. So from 2010, with a fairly narrow definition, to 2020, we have now thinking that there are close to 10 million individuals who identified as American Indian and Alaska Native. What is very important is that the diversity of the Native American population is enormous. There are 574 federally recognized tribes and counting. And there are about 200 state recognized, and then you have community recognized. So there are a lot of tribal communities that we are interacting with. But the main thing for us to remember is that approximately 70% of all American Indians, Alaska Native, reside in urban Indian communities. And the biggest urban Indian communities are starting with New York City and going to Los Angeles. So these are huge Native American communities, but they are spread across the country. As you can see, there are 206 substance abuse treatment programs. There are, I don't know how many mental health, and then you have 41 urban Indian health programs across the country. And if you look at the American map, this is what the American map looks like when we look at the population of American Indian and Alaska Natives. And many people ask me, why on earth is most of the population west of the Missouri River? Think about it. The Trails of Tears started with the signing of the law by Andrew Jackson in 1830. And that meant that people literally walked from the eastern seaboard, and many tribes were put into Oklahoma. And then you have Arizona, the four corners, and the upper Midwest. However, if you look at Alaska, Alaska has the highest number of tribes in the whole country, 220. So it is different population at different places. And Trails of Tears wasn't only going west, it was going north to south and south to west, up along the West Coast. It was a movement of people that we have never seen before. The map is interesting. When we work in the federal government portfolio, we have to deal with this map, because that map is the map of the 10 DHHS regions. And we have an ATTC, an MHTTC, and a PTTC in every single one of those. We have to deal with the Indian Health Service Health Organization. And that looks like this. And these maps are not easy to transfer, but just imagine my students and staff have two maps three maps in front of them. These maps and the time zones. Because if you want to have people in Alaska engage with us, you need to start from there and move east, because otherwise they are not going to be out of bed when we start our program. But here's another thing that we think about: how you think about Native American communities, how you think about the Native population. The reason why I'm asking you that question is because it is so easy to see all the deficits in this community. There are so many health disparities. There are so many health risks associated with being identified as an American Indian Alaska Native. What we forget is the strengths in these communities. So just imagine these communities from the settlers came out to the East Coast in sometime 1620, 30, to now, they have been affected by a lot of traumas, but they're still here. So what we do is we need to know very much what you see on the left side here. We need to know about the chronic diseases. We need to know about the mental health disorders, the accidents, the poverty rate. But when we initiate programs, we look at the right side. We want to have an understanding of a holistic understanding of the health of these people. We need to listen to them. We need to understand what their perception of their needs are, because if you just tell them, they're going to sit very politely and look at me, and it was going to go right over their head, in one ear and out the other. So what you do is to focus on being humble when it comes to culture, be willing to learn. One of the things that I very often have learned is to really say, I don't understand. You need to hold my hand and tell me, and immerse myself in different cultures all over the country. And the day I was made fun of, and this is important because humor in Native culture is crucial. The day I was made fun of, I knew I was okay, because they didn't tease unless they felt safe with me. And from then on, it was like when I asked the question, what am I supposed to wear when I am part of what we call a vision quest? And my colleague Dwayne said to me, Elena, slacks. Well, I had conducted a board meeting that morning, so my slacks were my suit pants. So I walked down the steps in the hotel, and he starts laughing his head off because he said, Elena, you can't use these after you've been there, because we were sitting, of course, on the ground anyway. And from then on, I would ask him way in advance, you need to tell me so I can be prepared. But those are the fun memories. And one thing I want to say about the chronic diseases that I forgot to mention for you, oftentimes what we hear is, look at the alcoholism rate. 6 times compared to the general population. What this statistics does not say is that only a third of the population has a serious alcohol problem. This is a population where the percentage per capita of people who don't consume alcohol at all is the highest of all population in the United States. So these things is an example of why we focus on the strength. What we also need to really focus on is, what kind of food do people eat? What do they like to listen to of music? How do they dance? Have any of you gone to a powwow? Anything as beautiful as the powwows in the Meskwaki settlements in August is worth a visit that weekend. Also looking at the regalias, which is the dresses people wear, and the arts and crafts, and getting used to the fact that when I have Native students in class, they are beading. So you see them knitting and beading all the time during class. And that's a cultural thing. That's what you do when you focus and concentrate. When we work in Native communities, it's very important to understand the history. Understand the history of how we as Westerners have objectified them and studied them and not taking some of their specific needs into consideration. And those are important things to know. We have neglected very often to understand Indigenous knowledge and the sovereignty of each nation, the self-determination of the people, and also know that WHO has developed and acknowledged Indigenous knowledge. So it's not something out there eccentric. This is something that WHO take very seriously. Cultural norm confidentiality, very important to understand. And when I'm saying confidentiality is, think about walking into Hy-Vee in Iowa City. It's very hard for us to not meet somebody we have seen. If you are in a Native community, very difficult to hide out because they are so small. So as a researcher, as a professional walking on tribal land, that's one of those things we work very hard on maintaining. And the gold standard for working in Native communities would be community-based participatory research and program. That means they are engaged with us from the get-go. And we are engaging them, conducting meetings with tribal council, with urban Indian providers. They are in on the ground from the beginning. Otherwise, it could be like what I heard in Navajo one day. Some fancy colleague of ours went on Navajo and wanted to conduct a survey and did so, but had not done anything in advance. So the elder women got together and said, let's just give him something, but let's not be close to the truth. So what that means is that if you don't have buy-in, you can't really expect that the research you're doing will be solid. And one of the things that we always do, and I'm sure you noted that in Native communities, we have serious suicide epidemics. When there is a suicide epidemic, it's like a natural disaster. The federal government comes in, there are natural disaster declarations, et cetera, and then they ask for support. We do not go in, even though we are very trained to provide services in the middle of suicide epidemics. We don't go in until the tribe invites us. And before we go in, we will go figure out what the history is behind nationally, regionally, locally, and understand the specifics with the tribe if there are specific issues that make them more distrustful of outsiders. And then we want to know and communicate with elders. We want to communicate with spiritual leaders. And it's important to note, and if Sean had been with me today, he would have told you that his grandfather told him until 1978 that whatever we do in the longhouse, you can't talk about, because they didn't get religious freedom until 1978. And one of the things that are very tough to think about, but we need to be reminding ourselves, is that oftentimes their decisions about their health was not their own. And I know this has happened to many, many other ethnic groups, but there are things that have happened that the tribal communities had no impact on or didn't even know until years afterwards. So the indigenous view of health is important. Thinking about this from a decolonization perspective is also very important. And I'd like to let you know that at one point in, I think it is in February, we're going to have a conference virtual with people from several parts of the world representing indigenous knowledge, and have them share similarities in experiences that will affect our way of doing research and implementing programs. It's also very important to respect indigenous leadership. And when I'm saying that, understanding that in a tribal community, there is an election every other year, sorry. That wasn't how the leadership was in the old days. So the leadership that is implemented from the federal government onto the tribes are not necessarily easy for them to adjust to. But one of the ways they have done this is to be militantly democratic. So they take their time making decisions. They want different parts of the community to hear and have input on whatever we bring them or whatever they are going to make decisions on. So they take their time, and we have to respect that time. So here are some of the concepts that we use when we work with Native communities. Culture is prevention. And when I'm saying that, I really would like you to think about, just imagine if someone said to us, no, Christmas is out this year. That would have been very difficult for us who are identified as Christian of different kinds of denominations. This is what happened to the tribal community, and we are helping them bring back some of the culture, because that gives structure, that gives meaning, that gives purpose to their way of life. One of the things that we also need to say is that clinical practice need to be trauma informed. So that's why we have to know what our specific population, tribe, urban Indian community have been exposed to. And prevention practices also need to be trauma informed. And the latter isn't necessarily intuitive, but if we use Western model on how to raise awareness, how to initiate prevention programs, we often are quite clear on what people need to do and not to do. That can be re-traumatizing. So you have to really think about, what do we need to do to avoid that, and how can we develop a prevention program together with the community? And I will give you examples later. We do a lot of TA, and that means when we do initiatives, when we do trainings, we will hang in there with the community and provide technical assistance. And the difference between technical assistance that we provide to a community in Iowa and a Native community is that when we engage with that Native community, we engage for a long time. Because a lot of times it takes them, as I said to you, decision-making process takes a long time. And they may come back to us and say, but we tried this and we don't know how this is working. Can you help us with this? So it's a long-term commitment. When it comes to, and this is a model that is developed by Everett Rogers from Iowa State, who developed the model of the transfusion of innovation, diffusion of innovations. So that was built on how he managed to get corn farmers who raise corn to change their practices. And then when we develop projects, we use this model down here that the ATTCs developed in 2001. And what you see are stages, and then we put this into a cultural perspective. So we have to do development. We have to look at what is the evidence-based practice. How do we want to translate that? How do we want to disseminate it, facilitate adoption, and how do we want to support people in implementing this? So these are the two conceptual models that we use when we develop programming. So here is some examples of what we have done and how we have implemented the technology transfer model into a cultural perspective. For those of you who recognize this room, this is the boardroom in the old Capitol Mall. That's how I think about it. And we are sitting here with tribal leaders from all over the country and staff, and me included. Here are several staff members. We're just sitting there. We are taking notes. We're making sure we are able to understand this. And we have tribal leaders like Ray and Ed, who are talking to us about what this, an essence of an innovation, what that means if we're going to put it into action in a tribal community. And that started with Dr. Mackeys program in South Dakota. We developed a workforce development program for providers in South Dakota who were substance abuse providers and working with natives. And one of the things we found very early was that 46% of the providers were non-native women. And the average age was 46. And they treated natives with no cultural knowledge. And the provider or the single state authority in South Dakota was looking at the data and thinking, we need to do something here because we are not doing a good job. So that was the beginning of the Native American Cultural Sensitivity Training Program that later in 2006 was given the award of the most innovative initiative in workforce development. And now we are in the middle of disseminating that across the country. But think about this. This is developed for Santee Sioux and Sioux tribal members. There are 573 more of these. So what we are doing is starting a program where we are sitting with different tribal members and thinking about how can we do this so your tribal provider can adopt it and the non-tribal providers can understand what's going on when they do treatment and prevention in tribal and urban Indian communities. Another program that I wanted to share with you is the Healing the Returning Warrior. Why is that important? Because PTSD, post-traumatic stress disorder, in Native returning veterans are more serious and more chronic than PTSD developed within other groups of veterans. And secondly, what we do know is per the community, the Native Americans are enlisting in the armed forces at a much higher rate than many ethnic groups. So with that background, I want to direct your attention to the pictures here. This is, and this is another thing we do. We try to engage with the Native communities in the communities we work. So this is taken in front of the Code Talker pictures in the Meskwaki Casino and Hotel. And just to make you understand the pride, and sometimes we forget this, the Code Talkers didn't just appear from the Navajo Nation in 1944. It was the Choctaw Nation during the First World War that did the code talking. And the German army did not manage to crack the code. So during the Second World War, almost all tribes across the country had code talkers. So these are code talkers from the Meskwaki settlements. And this is Sean Beer, who couldn't be here. And this is Ray Daw from the Navajo Nation. They are heading up this project. And this is when the consensus panel met and hammered out a program. This was in, let me see, it was in January, guys. Not the best time, especially thinking about the weather we have at the moment. But these people came from all over the country, and the women in front are the staff. So we were just sort of window dressing, and they hammered out things. And this is a very, very popular program because we have several Native trainers, because we've trained them to do this. And it's requested very often now when we are in need of the social distancing. We are trying to do it via Zoom, and we have done that, but it's not as easy because it's very emotional for our trainers. These are all returning veterans from different disciplines within the U.S. Armed Forces. And the main thing is to make the providers understand the pride that these Native soldiers have towards the United States, towards their accomplishments. So that flies in the face of the fact that they have historically experienced a lot of traumas. But this is an important program. We are very proud of it. I want to direct you to another thing where we did the same model. The Native LGBTQ two-spirit community has been seriously affected by suicide, by depression, by drug and alcohol use. And historically, the LGBT community was very accepted and had very clear roles in the Native communities. They had roles that they played during battle and in peacetime. And one of the things we've seen in recent years is that LGBT leaders have taken back some of that role. To give you an example, there are graduation ceremonies of kids in high schools that are conducted by the LGBT community, because that was the kind of status they had before the settlers came. This is a group of professionals from all over the country, from Alaska to Florida, and of course staff. And they developed a very important curriculum that we call Honoring Our Relations, Increasing Knowledge of Native LGBTQ Two-Spirit Wellness. And just to give you an idea, Two-Spirit is a concept that was introduced around 1970, 1980. Some tribes do not like that concept, but the Two-Spirit community have identified over 102 to 104 different words to describe their specific circumstance. So it's a very interesting thing to look at how they are now taking back the pride again. And we have based our curriculum on this group of consensus panelists and trainers. And we are also offering it with technical assistance over Zoom at the moment. And this time we decided to go to California because the VA project was almost impossible to implement because of the weather. I'm sure that some of you who are working with counseling students and counseling faculty, psychology faculty, know about the method of motivational interviewing. Motivational interviewing is developed by Bill Miller, and he was in New Mexico, and he worked very closely with tribal leaders in New Mexico. So this method is very much in tune with the cultural way of communicating. However, there are so many different tribes, as you know, so motivational interviewing has been adapted to tribal communities in Southwest and to tribal communities in Northwest. What we did was to decide that let's focus on the upper Midwest a little. Let's think about other specific things culturally we need to take into consideration. Also, we asked ourselves, how do we make sure that we don't use a Western-based training model on implementing and training Native staff to do something that is really very conducive to their cultural way of communicating. So we are running the spirit of communication, motivational interviewing, and traditional teachings. And we have specific Native trainers who are doing this for us. And it is very often offered. Some of you wanted me to address the Leadership Academy. And the Leadership Academy was developed, again, using a consensus model. However, the ATTC developed a Leadership Institute around 2004, and we offered it annually to the regions we were working with, and that was the Upper Midwest. I asked Wayne one day, I said to him, why on earth aren't we able to attract Native up-and-coming leaders? He looked at me and said, this leadership model doesn't work in Native communities. At the same time, as another very prominent behavioral health providers in Standing Rock said to me, you have to help us because look at me, I'm gray and I'm going to retire and we need leaders. So what we did was to take And this is the lead, this is the person, Pam Waters from Florida, who developed this Leadership Institute. And I invited her to campus. We're standing outside our department. And I looked at all my colleagues and asked them to send and volunteer some of the graduates from the Leadership Institute to sit with us and do this. And we sat for 3 days and we developed a culturally informed leadership academy. And we are in the middle of evaluating this. It is looking very good, but we have no data to report yet. And this is the last cohort we have graduated. Here we have 11 mentees, and we have 12, 13 mentors, all native, working on training, supporting, providing clinical and administrative supervision during the implementation of their specific projects. And this specific cohort is very near and dear to my heart because we have 3 face-to-face events usually. And the first one starts in the settlement, which is where you see the pictures from. And then the next part, and in between these face-to-face events, there are lots of meetings on Zoom and discussions and telephone calls, etc. This group met in Tamaya, Santa Ana Pueblo in New Mexico. And we sent them off, and just think about the date now, on the 28th of February, 2020. And I was to give the closing remarks, and I said to them, guys, you're going to be tested. We are heading into something that is very unknown to us, but is going to be very serious. It was before it was declared to be a pandemic, but we had one of the regional administrators present, and she was dressed in field uniform because she was going to be deployed to northeastern tribes, because that's where it started to be very difficult. And they all looked at me and said, "You're scaring me." And I remember I said to them, guys, I'm not trying to scare you. I'm just trying to motivate you to pull out all your leadership skills because you are going to need it. And they did. They had started their projects into half of completion, and come mid-March, as you remember, 2020, they just had to scrap it and just go and change everything. And we had to stand back and help them. And I'm going to address that a little later and tell you how we handled exactly that situation in March of 2020. Tribal Opiate Response Program is a program developed for natives only. And the result of the opioid crisis was that the federal government decided we need to do something specific for the tribes. So they developed the TOR program. And this is a picture of a cohort that we met with in the urban Indian and behavioral, the epicenter in Sacramento, California, but with tribes in that area working with us on how to implement what we call medication-assisted treatment, which is how to help tribes start using methadone, buprenorphine for replacement of opioids. And again, what did they struggle with? They struggled with, how are we going to take evidence-based practice, which is MAT, and implement it and be able to make people adopt it in tribal communities. So we sat around, we meet with them regularly, several times a month still. And I think there are 200 tribes across the country now receiving this funding. And they started sharing with us what they did and how they managed to do this. And again, from a strength-based perspective, what we did was to ask them, can you describe what you did? And we put it into a compendium that is publication in, what should I say, progress, because we're never going to be finished. We are adding to it, but this is something that you can find on our webpage, and you will see how they integrated their culture into the use of medication-assisted treatments. Let me switch gears from substance abuse to mental health. And one of the things that we have done with that branch of our center is to really do things like understanding what was going on with mental health treatment, and then how can we help them bridge the gap between Western, the DSM-5, and the more spiritual, medicine-based way of looking at mental health. So we went back to look at what did this look like. And there's only one asylum for Indians, insane Indians, ever established in the US. And that was in Canton, South Dakota. And the Congress implemented that, and it was closed down later on because by review from different psychiatrists, psychologists, it was found to be a place, it's almost like a prison more than treatment, and very little mental health treatment took place. This is now torn down, the building is torn down, and there is a graveyard in Canton, South Dakota, that is in the middle of a golf field. But if you go close to it, you see all the gravestones down in the ground in the golf course with names and where they came from. It's a sobering experience to be there. But from there, Sean decided to really look at what does it look like on the cultural, spiritual, medicine side of Native American culture, and what does it look like from the DSM perspective? Because one of the things that we know is that when some of the Native community members are diagnosed with a mental health illness, we're using the DSM. However, I'll give you a couple of examples. That can be very misleading. And one of the examples I will let you hear is one of my colleagues, also a deceased veteran, PhD in clinical psychology, was had an appointment in the VA to be diagnosed and assessed when it came to PTSD. And there was a question that came up. And the question was, do you speak to animals? And he said, yes, as a matter of fact, I do. And in recent weeks, I have had to do that fairly often because I've been visiting by the owl And in Sioux culture, owls means death. He was in a situation where he lost a lot of family members, and that was how he was given a forewarning. He could read upside down, and the resident wrote paranoid schizophrenia. And he said, this conversation is over. I'm not talking because I'm not paranoid schizophrenic. So that's one example. Another one is a dear friend with beautiful long hair. And you need to know that you don't throw hair. Some tribes, you don't tuck your hair. You collect your hair and you get buried with the hair after you die. So she is sitting there with all her beautiful hair and a lot of hair, and she's putting it and sort of wrapping it around her finger. And I'm a clinical psychologist, and one of my colleagues, wherever this was, said to me, this is obsessive compulsive. And she said, no, it's not. This is what we do in my culture. We do not throw away any part of our body if we can avoid it. That includes DNA. We need to be buried with it because all parts, all life has a soul, and we're not going to disregard that. So we have been running what we call the spirituality roundtable with tribal leaders with advanced behavioral health degrees and spiritual background, and talking about how do these different disorders get described in Native communities and in the Western community, and how can we bridge that? The second thing we do here is we have started working on issues surrounding how do we deal with dementia in Native communities? How do we help the elders that is put in really in high regard when they start losing some of their memory? And this is the first of a kind. And at this point, I think we have several elders in the Meskwaki settlement and in other parts of the country reviewing this and giving us feedback on how to proceed, how to make changes, what to consider. So as you can tell, when we work on projects and programs, it takes time because we are very interested in reaching out, building consensus, and then we get buy-in. People use it, what we do. Within the mental health program, we have a K-12 school supplement. And we have developed several things that is very important for kids. Tribal schools are financed through the Bureau of Indian Education. And there are, in addition, 33 tribal colleges across the country. However, what we discovered, and this was after I hired a prominent member of Koheri tribe in North Carolina, who also had been the principal at the Meskwaki school, what we discovered was that the kids in tribal schools often are taught by non-tribal members, and the social emotional support for the kids may not be culturally appropriate. So we have started working on programs for that and to support school staff. But then came, of course, COVID, and what we discovered was that in July, August of 20, Bureau of Indian Education wanted every school in Native communities open. The only problem with that was that there was no support provided. So we developed a very extensive program supporting teachers in how to start up during COVID. And then one thing we have discovered very early is that there's a lot of bullying, very tough school environment in some of the tribes. And we decided to assist communities in developing a crisis plan. And we used the same model as we've done before. We worked on how to make sure that they develop their own crisis plan. And we gave them some of the, like an opening webinar by the person who developed this in Oklahoma, and she's a tribal member and a colleague. And we asked her to give the tribal communities an overview of what this might entail. And then we ended that awareness raising webinar by saying to tribal communities, we will be helping you develop a crisis plan, but you need to give us an application and you need to give us commitment, because we knew that if we do this, it's going to be very time consuming for us. And we want to make sure that the tribal communities really are committed to doing this. And we have had a lot of meetings, of course, face to face, but not anymore. And that now has developed into some tribal communities having a crisis plan. And as you know, with COVID, and then throw in all the natural disasters we've had, very rarely do you hear what happened in native communities. But what we did, to give you an example, when the tornadoes hit through Kentucky and that part of the country, we started looking at where are the tribal communities here? What do they need? And of course, they needed a lot of support. Let's switch to prevention. And as I said, culture is prevention, and preventions need to be trauma-informed. So the federal government, a long time ago, it's actually now 12 years ago, developed what they call the culture card. And that was sort of like something that you can put in your hand, but then you can stretch it out and you can see so many good suggestions for how to work with tribal communities. When my coordinator took over the job, she decided to go into certain aspects of this. So what she did was to have a group around her again. She is a tribal member from Africa and has the indigenous knowledge background. And she developed all these culture cards, we call them. And we have printed so many of these. They fly off the shelves. So because they are very clear, not a lot of explanations, but a clear understanding, conveying an understanding of what you need to do when you want to develop cultural programs. And here is the health promotion technical assistance program that we developed. And this is the same as we did with the crisis and resiliency. We had our health communication specialist, non-native, and she developed an overview. What is the principle of awareness raising, health campaigns, prevention campaigns? And then again, people had to apply because we spend a lot of energy and support. And some of the, I don't know remember how many communities, and this is one example. This is from the Buffalo Urban Indian Program. And the person who developed this was a graduate from our first Leadership Academy. And she developed this, a kickoff meeting and initiative to combat COVID stress. And it was very successful. We did all via Zoom, and we're going back to the field, but I know we want to hang off a little bit because, as you can imagine, the Native communities are the hardest hit when it comes to COVID, but it's also the community in the country that for a long time have had the highest rate of vaccination of all ethnic groups. So they were able to combat this even though they had limited resources. So let's talk about the COVID. So remember I told you that I warned my Leadership Academy graduates that they were heading into uncharted territory. And we were also in that boat. And I remember when we were sent home to work from home, I'm sure you can remember that, even though it's 2 years ago, close to. I instituted a daily meeting called Coffee with Unwayne. And staff were on the Zoom every morning at 9. And we were sitting there brainstorming. And I thought, I have no idea what the tribal communities need. What I do know is that this is going to be very tough. They have very limited resources, and whatever we can do would be important to the community. So I threw at my staff, let's create listening sessions, which is very in tune to the cultural way of thinking. Let's not go out as a federally funded grantee and tell them this is what you need to do. So we developed a listening session for every single one of our projects. And we ran 7 to 8 listening sessions a week. And what that really resulted in was that we got and we were the only one of any provider organization for Native communities doing this. So we had people signing in all the time. We had staff introducing. In the beginning, it was an open flowing discussion. And then we decided to create resources guides, and we gave them resources every week to look into. And we were exhausted. And I called my advisory council and I said, you guys need to step up here because we can't manage all this. And they said, absolutely. So we had advisory council members from all over the country supporting us in this. And one of the best compliments I've ever had was this: thank you for letting us be Native. And I'm just bringing you one of them that was something we still have going. And it was a virtual talking circle with an elder called Fred Littlebald-Eagle from Rosebud Nation in South Dakota facilitating this. And people shared with each other what they struggle with, gave each other support and suggestions. And we were reaching a lot of people. And as you can see, there was a lot of positive feedback with suggestions of improving quality of life, learning things that will help me in a culturally appropriate way, and gave me the opportunity to be more resilient. The future is in the younger generation. So one thing we have done is to think about how can we gather input from elders, and younger people. And this is the first youth panel we did. These are up and coming, very impressive young people. And one of them, Keely Driscoll, remember I told you about the land acknowledgement. She was part of that. She's a pre-law and she is in our center. And they all discussed how can they make a difference in their community. What do they want leadership to look like? And how can people working in Native community encourage and support youth? What inspires them? And how can they make a difference? And this is on our YouTube channel. So if you want to listen to this, you can find it. We also have this, the one we did in November for American Indian Heritage Month. Another thing that is important is the future lies in supporting sovereignty, giving the Native communities a way to help themselves, become less dependent on outside support. And that means how can we educate community members to be behavioral health aides and develop a support network in their tribe. And we're hoping to pilot this upcoming year. And it's very extensive, and I'm hoping that we can get support from the University of Iowa, etc., to do this. It's a huge undertaking. What I'd like you to know is that in doing all this, I have developed a lot of connections. I have a very extensive network. And here is a picture of some of our Native leaders giving us advice on how to start this. This is a picture from January of 2013. And here are some of the names of my advisory council members. There's one person who's not Native here. But we also do this. We ask people who are working in schools to give us advice, people working with spiritual issues. We ask advice from ex officio members. But one thing I want to show you here, and I'm sure you have seen some of this in the press, there is a very great focus on murdered and missing Indigenous women. And that's one of our initiatives. And here, we do not give names because the participants here are survivors. And we just want to make sure we hear their voices, but we're never going to give out names. So with that, I will say thank you for honoring the honor to address you today. And I'm sorry, I just left about 15 minutes for questions, but I'm ready to answer as much as I can.